All right. So we got a great talk for you guys on this next one. I think it's super important. So I'm going to introduce our two speakers today. First is Dr. Faustine Ramirez. So Dr. Ramirez is a primary care sports medicine doctor who cares for pediatric and adult patients with a wide range of musculoskeletal conditions. She has special interests in musculoskeletal ultrasound, bone health, growth plate injuries, and care for adolescent female athletes. In research, Dr. Ramirez focuses on understanding how sports specialization affects mental health and burnout, bone health, and injury risk in young athletes. She also conducts research on improving musculoskeletal and sports medicine education for pediatricians. Dr. Ramirez earned her medical degree and completed a residency in pediatrics at UCSF. She completed a fellowship in primary care sports medicine at Stanford University. Throughout her schooling, she was honored with several awards, including an award for her commitment to career in sports medicine from the American Medical Society for Sports Medicine. During both her residency and fellowship training, Dr. Ramirez has provided medical coverage for many Bay Area sporting events at the high school and collegiate levels. At UCSF, she was team physician for Lowell High School and led educational workshops for student athletes on wellness, sports performance, mental health, and injury prevention. At Stanford, she served as team physician for many of the varsity sports. Dr. Ramirez was born and raised in San Francisco. As an undergrad at the University of Washington, she was on the women's soccer team, serving as captain during her senior year. They got so close this year, so close. She is the perfect person to discuss female athlete performance with you today. And her fun fact, because as you're all getting a fun fact, she's a ninja at sneaking vegetables into food for her toddler. So if you guys need suggestions for that, put it in the Q&A. And then alongside her is Dr. Steph Wong. You guys met Dr. Wong yesterday if you were here. Or was that yesterday or Thursday? Thursday, yeah. It's all blending together. Dr. Wong's a board-certified orthopedic surgeon and sports medicine specialist who cares for athletes of all ages with hip, knee, or shoulder injuries. Her expertise in hip conditions includes labral tears, damage to the ring of the cartilage that lines the hip socket, and femoral acetabular impingement, as well as injuries to the nearby hamstring and gluteal tendons. If you guys were here on Thursday, she had an amazing talk on hamstring tendons. She specialized in advanced arthroscopy, there it is, for hip preservation, and including a tiny camera, and passes through very small incisions. Dr. Wong treats knee ligament injuries, such as ACL and damage to the meniscus. In the shoulder, she treats a variety of conditions, including rotator cuff tears, biceps injuries, and shoulder instability. Dr. Wong has published numerous articles on her research, including studies on ACL injuries, rotator cuff tears, and outcomes in patients who have shoulder replacement surgery. She's also interested in studying the use of patient-reported outcomes to guide decision-making on surgery. Dr. Wong earned her medical degree at the University of California, Davis School of Medicine, graduating with election to Alpha Omega Alpha Honor Medical Society. I don't know what that means, but it sounds really good. She completed a residency in orthopedic surgery at UCSF, where she received an award for going above and beyond to create a wonderful experience and excellent care for patients and their families. She's also completed a fellowship in orthopedic surgery and sports medicine at Midwest Orthopedics at Rush University. One of Dr. Wong's passions is inspiring young women to pursue careers in orthopedic surgery. She's also served as team doctor for high school teams in the Bay Area and in Chicago, and as an assistant team doctor of the Chicago White Sox, Chicago Bulls, and the Chicago Steel. Fun fact for Dr. Wong, no day is complete without a scoop of ice cream, which that's my favorite fun fact of the day. So please help me and join me in welcoming Dr. Ramirez and Dr. Wong.
Thank you and good morning, everyone. We're so excited to be joining you this morning. We had a couple cases we wanted to go through and just some great information, and then we'll have some time for a Q&A at the end. We don't have any disclosures. Some slides are courtesy of our own very great PCMS and Dr. Carlin Center. All right, so the objectives of our talk today are to be able to design an injury prevention program for female athletes, developed a safe and individualized program to guide postpartum return to physical activity, perform shoulder exam maneuvers to diagnose adhesive capsulitis or frozen shoulder, design a resistance training exercise program for postmenopausal women, evidence-based osteoarthritis treatments, and then recognizing key features of relative energy deficiency in sport. So we'll go ahead and kick this off. So case number one, this is a 15-year-old girl presenting to you with bilateral anterior knee pain. Doesn't describe any specific injury. She enjoys playing competitive soccer like Dr. Ramirez. She has tried some rest but still having pain, notices that it's worse with squats and stairs, and also with getting up from sitting for a long time. Her dad's with her. He's really worried about her knees because she's had 2 teammates this season who are out for the whole year with an ACL injury, and he wants to know if she's at risk of that. So this will be an audience response, but because I'm not technically savvy enough to do it on the app, we're just going to do a show of hands, okay? Oh my God, you're the best. Thank you. Okay, so open up your app and please answer this question. So for this patient, what's the next best step? Do you want to A, order bilateral knee MRIs to take a look at some of the structures? B, provide a steroid injection to her knees? C, refer her to Tim and our orthotics group for a hinge knee brace? Or D, refer her to physical therapy? Oh, wonderful. So I'll just skip this case since you guys don't need this talk. Just kidding. Wonderful. So 95% of you said refer to physical therapy, and that's absolutely correct. So this patient, if we could go back to the slides, has classic patellofemoral syndrome. So this really commonly affects our adolescent as well as female athletes with like a 2x incidence over some of our male athletes or patients. And they typically present with bilateral atraumatic symptoms, and they'll kind of describe peripatellar pain. So they'll draw out for you, like they'll draw like a U on the bottom of their knee, or they'll just kind of like, they'll have trouble localizing it. Typically is worse with squatting, stairs, sometimes with running sports or for sitting for a prolonged period of time. And this condition is typically due to muscular imbalance rather than like a structural injury, such as a cartilage problem. They tend to have weak core and glutes. And female patients have an increased Q angle. And what that is it's demonstrated on this diagram here, but because females have wider pelvises, you can see the angle coming down from their pelvis down to their knees is an increased angle compared, and that can predispose them to this condition. I like to check a single leg squat, which I'll show you some photos of in a moment. And that's a really great marker to say, how is their pelvis stability, how's their control? And if their knee is collapsing in, they look really shaky or unsteady, that can be something that PT can really target and help to improve this pain. So, I just wanted to bring up the fact that, women and girls who participate in sports and otherwise are really predisposed to injuries at different rates than some of our male patients. So for example, around the knee, ACL injury 2 to 8 times more common, and then patellofemoral syndrome, as we mentioned, but also other conditions as well. So frozen shoulder, relative energy deficiency in sport, which used to be called female athlete triad, stress fractures, ankle instability, as well as multidirectional shoulder instability, all show a differential kind of predisposition in our female athletes. So even though a lot of times what we do in medicine, it's very much, here's the problem, here's a treatment to fix it, whether that be surgery or non-operative, I think it's really relevant to recognize that these conditions occur more in female athletes and necessary to talk to them and think about screening for these conditions. So a couple injury prevention pearls that I wanted to share is that, in my opinion, and based on the literature, everyone should be doing some form of strength training and resistance training. I think a focus on glute, core, and hamstring will really, really serve you well for the lower extremity and core midsection. And this really helps to reduce all-cause mortality, cardiovascular mortality, as well as cancer risk and mortality in women. So it's really strongly evidence-based, aside from all the musculoskeletal benefits and exercise benefits you might have. When you have increased workloads, so for example, if you're doing more training, more exercise, lifting more, working out more, that should lead to increased performance. So people should be feeling better. If they're not, then you're probably overtraining or maybe not doing it with the correct form. So just keep that in mind. So more exercise, more training should not lead to more pain, more fatigue. And if it is, then maybe consult your local physical therapist for some guidance. And then I do think that this can lead to muscle and cognitive fatigue, and then you have injury risk that goes up. So sometimes we see this in our young athletes where sometimes coaches will say, like, we just need more practice time every day, et cetera, and they're not giving a lot of time for rest or recovery. And I think that sometimes just the sheer amount of volume can be detrimental, actually. So you want to strike that balance. Cross-training is something that I preach, so I think that, while I say do a lot of strength training, I think it's also really important to work on flexibility and low-impact exercise as well. And so if I had one thing that I could tell all patients was just that diversity of activity is really important, so just balance. And this would include things like resistance training, flexibility, aerobic activity, low-impact stuff. I think all really good in terms of just keeping the body healthy and happy. Okay, so some sports strategies. Shout out to Nina here, who's pictured doing a Nordic hamstring curl with one of our youth athletes on a soccer field, as well as Lexi, I thought you came in just now, who's one of our athletic trainers. So for those participating in sports, before you do activity and during and then recovery, I wanted to talk about some different strategies for this. Before, I think a dynamic warm-up is super important. We'll talk more about what that looks like. And this is a combination of balance work, strength work, as well as some flexibility work. A lot of times we see coaches just saying like, hey, just start playing or start running or start exercising. I think it's really important to do this warm-up, and this can take 10, 15 minutes. It's not a significant amount of time. During, you want to focus on correct form as well as technique. You want to make sure your athletes are equipped with appropriate equipment. So that means like well-fitting shoes, good protective equipment. They should be playing on surfaces that are appropriate for that sport. And then hydration is also, of course, very, very essential. And then recovery-wise, I touched on, but really important to give, athletes as well as just people in general time to rest, recover. Sleep is super, super important. I know, a lot of our young athletes have lots of demands on their time, extracurriculars, school, sports, and they really do need, adolescents do need more sleep than adults. So I think that's really, really critical. And then stress reduction, right? We live in a really stressful world, and I think stress can play a role in how we feel and how we perform as well. And then finally, hydration and fueling. There's a great session coming up this morning by our nutritionist. She's going to go over some nutrition strategies just to make sure that when you're not exercising, that you're fueling and hydrating properly. All right, so, and then for some sports-specific strategies, so I just wanted to put a plug in for our Women's Sports Medicine Center. So we're a group of female physicians, sports dietitians, physical therapists, ortho and primary care docs who care a lot about female athletes and sports. And we do provide screening for some of our patients. So, and I think you can see that here with the, one of our PTs, Erin, doing some hip flexor flexibility testing. Dr. Nirav Pandya, who you heard from in the session before, he has really kind of pioneered how important it is to keep kids in multiple sports rather than doing single sport specialization. So if you have more thoughts about that or you want to learn more about it, you can look into his podcast that he does with Dr. Feely and Dr. Lansdowne called 6 to 8 Weeks, but they talk on a whole session kind of about the importance of staying in multiple sports throughout childhood. Those athletes are prone to less injuries and also actually tend to perform better. So they get more NCAA scholarships, and they tend to proceed to pro-level sports at a higher level than kids that specialize in a single sport early. So just keep that in mind. And then in terms of neuromuscular training, so this is something that the PTs can teach you as well, but I think just really, really important. If you look at this diagram, it says good and bad, and it's as simple as doing a squat. So if you ask patients in clinic, and I don't like to give them a lot of prompting, I'll just say, can you show me what a squat looks like? And you'll really see a wide variety of form. And if you see this one on the right where you see the patient's knees like collapsing in, that is bad form. That means they have weak core and glutes, and those patients are going to be more prone to injuries in their knees, hips, and ankles. So you really want to target that. Evidence really supports it. It does reduce injury risk, and the compliance is critical. So it's not just doing it while you meet with your trainer or physical therapist, but really, every warm up before every practice, et cetera, I think is critical for this to work. One program that does a lot of this neuromuscular training, and you can use this as a dynamic warm-up, is called the FIFA 11 Plus program. I'm a big proponent of this because, number one, it's free and publicly available, so you can download this PDF online, which I'll show you. And you essentially need no equipment. You just need space. A couple of the exercises involve like a partner, but if you're doing group sports, I think that's pretty simple. And you just need a space to warm up, so a field or a court, for example. And there's 3 different parts. It goes through running exercises, strength, plyometrics, and balance, and then some more running towards the end, and it takes about 10 to 15 minutes to complete. Just wanted to zoom in and show you there's like 3 different levels, 1, 2, and 3, starting from beginner to advanced, but essentially, taking you through a dynamic workout. And this can be really your warm-up. So you can see a combination of some core work, planks, side planks, balance stuff, hamstring exercises, squats, and then it advances to more plyometric stuff, so jumping, and then finally running, cutting, and pivoting. So I think this is really great and has been shown to reduce injuries throughout the lower extremities. So why not do this, right? And I think if the coaches are supportive, I think that'll translate to the team being consistent with doing it. Okay, we'll start off with case number 2 with Dr. Ramirez.
All right, so moving on to our next case, a 33-year-old woman with no past medical history presents for an annual exam. She is 3 months postpartum from her first pregnancy, which was uncomplicated. She exercised 3 to 4 times a week prior to her pregnancy, including running and lifting weights. She was cleared by her OBs to return to physical activity at her 6-week postpartum visit and is seeking your advice on how to return to her previous level of activity. How would you advise her? So take 30 seconds to think about this or chat with your neighbor before we move on. All right, I'm hearing some great discussion. I love it. So we're gonna move on here. Before we dive into the recommendations, I'd like to take a moment to highlight the many benefits of postpartum exercise. So postpartum exercise reduces the symptoms of depression and anxiety, improves pelvic floor health, including reducing the risk of urinary incontinence and pelvic floor prolapse, improves low back pain and pelvic girdle pain, improves cardiometabolic health, including weight, BMI, and lipids, and reduces the incidence of diastasis recti abdominis. This is specifically for core strengthening exercises. So the physical activity guidelines for Americans from 2018 recommend at least 150 minutes of moderate intensity aerobic activity a week in the postpartum period. They also encourage women who regularly engaged in vigorous intensity aerobic activity or who were physically active before pregnancy to continue these activities in the postpartum period. And they encourage women who are pregnant to consult their healthcare practitioner about whether or how to adjust their physical activity after the child is born. Similarly, the 2020 WHO guidelines on physical activity and sedentary behavior in postpartum women recommend at least 150 minutes of moderate intensity aerobic physical activity throughout the week, incorporating a variety of both aerobic and muscle strengthening activities, recommend limiting the amount of time being sedentary, and recommend starting small, gradually increasing the frequency, intensity, and duration. And finally, in 2021, the American College of Obstetrics and Gynecology recommends a gradual reintroduction of exercise after pregnancy as soon as is medically safe, depending on the mode of delivery and the presence or absence of medical or surgical complications. And they state that regular exercise in breastfeeding women is safe and does not adversely affect milk production. So these 3 guidelines all really support and encourage postpartum activity, which is fantastic, but they don't provide a lot of specific guidance on how soon to initiate activity, what types of activities, and really how to progress towards more moderate to vigorous level of activity. So historically, medical clearance was recommended at the 6 weeks postpartum visit before initiating postpartum physical activity to identify any medical or surgical complications, any contraindications to initiating postpartum activity. However, this often creates an unnecessary barrier for women who may have difficulty accessing care in the postpartum period because of childcare responsibilities or other limitations, or who may be ready to resume physical activity sooner than the 6-week mark. It's important to note that contraindications to physical activity in the postpartum period do vary widely across international guidelines. But for this reason, an international group of clinical and exercise professionals set out this year to develop evidence-informed expert consensus on relative contraindications to moderate to vigorous physical activity during the first year postpartum. And the idea of this list of contraindications was to identify any woman who may benefit from additional medical evaluation for any contraindications, who may need further guidance or modifications to resuming physical activity. But otherwise, women without any of these contraindications were thought to be safe to resume physical activity in the postpartum period, specifically moderate to vigorous physical activity. So this list was incorporated into the Get Active questionnaire for postpartum, which is freely available online. And this questionnaire can be used by postpartum women to assess their readiness to begin moderate to vigorous physical activity. It's important to note that this list of contraindications is specifically for moderate to vigorous physical activity, and there are no contraindications to light activities of daily living, and this can be initiated at any time in the postpartum period. So the list of contraindications is listed here. I apologize, it's a little bit small. These are available online as well. And you can see this is a quite comprehensive list, and this is really meant to catch any woman with any medical or surgical complication who might benefit from further evaluation. But otherwise, women without any of these contraindications can likely safely resume moderate to physical activity in the postpartum period without further medical guidance or further medical evaluation. The consensus, the International Delphi study also identified some potential barriers. So these are not necessarily contraindications, but these are situations or conditions in which women may benefit from additional guidance or support or treatment. So these include mental health, pelvic floor and abdominal wall function, musculoskeletal pain, wound healing, relative energy deficiency in sport, poor sleep, fear of movement, lactation status, social or emotional support, and eating disorders. I mean, these are all factors that may influence a woman's ability to resume moderate to physical activity in the postpartum period and are important considerations when counseling women. So how soon can women resume activity in the postpartum period? The most recent set of national guidelines on postpartum physical activity came out of Canada this year. They were published earlier this year. And they recommend early initiation of light intensity physical activity, such as light walking, gentle walking, pelvic floor muscle training for all women. They recommend beginning moderate to vigorous intensity physical activity in the first 12 weeks postpartum in the absence of any of these contraindications that we reviewed. And the progression to moderate to vigorous intensity physical activity can progress once surgical incisions or perineal tears have sufficiently healed and vaginal bleeding does not increase with physical activity. There's a lot of research supporting the many benefits of early initiation of low-impact exercise in the first 3 months, especially for long-term pelvic health. What about pelvic floor muscle training? This can be initiated and is recommended to be initiated in the immediate postpartum period. So this does not need to await any type of medical clearance to start, and this should be performed daily for the many benefits that we previously saw. Instruction on proper technique from a pelvic floor PT is recommended for optimal benefit, but if women are not able to access pelvic floor PT, they can initiate this on their own, and I'll give you some resources that you can share with your patients at the end on that. What about aerobic and resistance training? So these same Canadian guidelines recommended an individualized, gradual, and symptom-based progression towards at least 120 minutes per week of moderate to vigorous intensity physical activity, such as brisk walking, cycling, and recommend incorporating a variety of both aerobic and resistance training activities. They recommend that returning to running and resistance training is thought to be generally safe once surgical incisions or perineal tears have sufficiently healed and vaginal bleeding does not increase with physical activity. So this is a little bit different than previous guidelines that recommended waiting until at least 12 weeks postpartum for returning to running. But there's really been a push towards this more individualized and symptoms-based progression that's really going to depend on each individual patient. And when we think about symptom-based, what does that mean? That means for monitoring for any symptoms such as pelvic pain or pressure, incontinence, pubic symphysis pain, SI joint pain, any type of pain that may increase with any of these types of physical activity, and that should really guide that progression. Once those tears or incisions have healed and there's no presence of bleeding, like we've said before. This is an example of an exercise progression in a postnatal runner. This is a little bit older, and this is a guideline that was recommended waiting until 12 weeks for return to running, but this is a really nice example of the type of slow and gradual progression that's recommended. And pelvic floor rehabilitation is really at the core of this progression. And again, ideally under the supervision of a pelvic floor PT, but if not, these are exercises that postpartum women can initiate on their own. So you can see there's, the first few weeks just starting with pelvic floor training, some light walking in the second, fourth weeks, starting things like squats, lunges, bridging. In weeks 4 to 6, starting with lower impact exercise, things like cycling, cross training. Weeks 6 to 8, doing more like power walking, lower impact exercises, adding some strength training with increasing weight and resistance, and then progressing to running a little bit later. But if a woman, based on, does not have any of those contraindications listed previously and is not having any symptoms, it doesn't need to follow this 12-week progression. And there are some women that will be ready to return to running sooner than 12 weeks, but it really does need to be individualized. So these are some resources that you can share with your patients. The Squeezy app, you may have heard of this, has been recommended by many OBs and pelvic floor therapists to help with pelvic floor rehabilitation. They also have a maternity program focused on pelvic floor health. The Get Active questionnaire for postpartum, like I mentioned, is a list of those contraindications that can help women identify their own readiness to resume moderate to physical activity in the postpartum period. It's freely available online. And there are so many online platforms and apps for postpartum training. These are some of the more popular ones. This list is not all-inclusive, and I have no financial relationships with any of them. But these are just some examples of programs for women that are seeking some more structured programs in the postpartum period, and they can kind of seek those that fit their needs more. Some of these have more Pilates, more yoga, more strength training. They all differ, and that's because every woman's going to have a different baseline level of activity and different goals that she's trying to get back to. And there are others as well.
Awesome. Thank you, Faustina. I would say, as a mom to also a toddler, I wish I had had access to these slides before having a baby, because I was told just don't do anything for 6 weeks. Okay, so switching gears a little bit, this will be another audience response question, so if you guys want to pull up your apps. This is a 49-year-old woman presenting with right shoulder pain. She's also right-hand dominant, so this is significantly affecting her. Started about 4 weeks ago. She was walking her dog. It pulled on the leash. She's now having some difficulty getting dressed. She also notes some pain at night. And she also said that when she pulled up to her office, she's having pain when she reached to get the parking ticket out of the machine. She's taking Tylenol, but not really having a really good relief. So on inspection, she doesn't have any muscle atrophy. Her shoulder is non-tender over the superior aspect at the AC joint, some tenderness over the biceps groove. On her range of motion testing, she has limitations in both active and passive motion and abduction, external rotation, and internal rotation planes. She does have good strength. She does have some pain with empty can testing. And then in terms of special tests, she has a positive NIRS. So how would you treat this patient? Would you recommend A, that she have a sling for comfort, B, a shoulder steroid injection, C, would you order a shoulder MRI because her shoulder motion's limited, or D, would you refer to a sports surgeon for shoulder arthroscopy? All right, so take a few seconds here if you want to answer. Oh, okay. Very interesting. So we have a little split of opinions here. So a little more than half said to order a shoulder MRI. And then about 46% said shoulder steroid injection. So I think this is great. Really, really interesting. And I think it's always scary when patients come in and they have limited motion. For this patient, if we could go back to the slides, so this patient has frozen shoulder or adhesive capsulitis. This affects about 2 to 5% of the population. Typical onset, about 40 to 70 years old, very much more like higher prevalence in women, as we talked about. characterized by both pain and stiffness, and the pain levels are usually quite high in early phases. Like, for example, some patients come in on opiates or having been to the emergency department for that level of pain. And the hallmark is that they have loss of both active and passive motion. And we'll show you how to evaluate for that. I like to say that the only other conditions that cause lack of both passive and active motion are severe shoulder arthritis or a fracture or a dislocation. And those other conditions you should be able to diagnose on x-rays. So if their x-rays look totally normal, they have frozen shoulder, okay? And, on a cellular level, they tend to have increased inflammation present. So this has been shown on synovial biopsies as well as serum blood marker samples. So this is just a pro-inflammatory condition. On the photo here on the top, you can see when you test external rotation, and if you're not sure how to do this, we can also walk you through this with some of our shoulder exam sessions coming up later this morning. But you just have them put their arms at their side and you just tell them to rotate their arms out to the side. It should look pretty symmetric. You can do it on yourself to try. You can see how this patient in the photo, her left arm, she lacks a lot of passive external rotation. If you want a recap of a video, like say if you go home and you want to review the shoulder exam, our YouTube website has a lot of great videos where we re-demonstrate it. So if you need a reference when you go home, you can check out our YouTube for UCSF Ortho. This condition is typically treated non-operatively, fortunately. So I love to see frozen shoulder. You can always refer them to us, but fortunately, I don't need to do surgery on them very often. So medical comorbidities are very prevalent in this patient population, and they include things like diabetes, endocrine conditions such as thyroid problems, obesity, tobacco use, as well as hand contracture conditions such as Dupuytren's, which is like a contracture in the hand palm. Current treatment options range from things like physical therapy, anti-inflammatories, intra-articular injection, which is the correct answer for this case, surgery, including manipulation under anesthesia. In this study, this just looks at the different types of treatments that patients received before diagnosis and after diagnosis. And alarmingly, that yellow bar is opiates. So if you look at this, and it's not infrequently that patients will actually request that, but I do think there are more appropriate treatments for this condition, such as injection and PT, rather than opiates to treat the severity of the pain. Some additional considerations. So I usually tell patients this I'll say, just so that they don't get too sad about it, fortunately, this doesn't need surgery. Unfortunately, it's going to take forever to get better. Forever meaning like months to a year. So I would set that precedent up front because then the expectations are that this is going to be a slow process. And the peak incidence of this really occurs around perimenopause. And so there's this plausible role of maybe sex hormone changes that give for example, the protective effects of estrogen decreasing, maybe predisposing perimenopausal women to this condition. There's not really any universally accepted treatment, so I do think there is room to explore new treatments and alternatives to what we currently do, which is PT and injections. Future treatment modalities, so hormone replacement therapy, I think the pendulum has shifted from, being don't give this to women to maybe a lot of more women should qualify and should be getting this. And because frozen shoulder occurs around perimenopause, we thought, if we can stabilize the level of sex hormones, and could this be a treatment for frozen shoulder? There are also additional benefits of hormone replacement therapy, including improved cardiovascular health, cognitive health, reduction in other menopausal symptoms, better bone density, better muscle mass. And actually, this came out very recently, so last month, but the FDA is removing the black box warning from menopausal hormone therapy replacement products, I think making this more accessible to lots of women. So we're actually initiating a randomized controlled trial at UCSF looking to see if hormone replacement therapy can be used as an adjunctive treatment for frozen shoulder. So very interesting. And anyways, our hypothesis is that they'll have better pain and range of motion compared to standard treatment, which would be PT and an injection. We're also going to do some motion capture where we have them move their arms through a workspace, which kind of mimics how you use your arms in real life. Because I would say our physical exam is good, but it doesn't really capture complex multiplanar movements, right? Like if you go reach to get something, we're measuring it's like forward flexion or abduction. So this software or similar softwares can help us understand the three-dimensional space that you can move the arm in. We're going to randomize to 2 groups, and yeah, so I think it's really interesting. I think it's going to be a great study. Thank you, guys.
All right, moving on to our fourth case. A 49-year-old postmenopausal woman with no past medical history presents for an annual exam. She enjoys running 2 to 3 times a week and is seeking your advice on incorporating weightlifting into her exercise routine. She also inquires about the safety and benefits of strength training for her 14-year-old daughter. How would you design a resistance training program for her and counsel her about her daughter? So again, take 30 seconds to chat with your neighbor, and before we move on, I'll give you a second. Should I do Brett's case?
Yeah, I think so. Yeah, because I think we've had a lot of talks on it. Okay. And a lot of mine is like repeated from a long time. Is that okay? Okay, perfect. I just want to make sure people have time. Okay.
All right, I hear some great discussion. Just for the purposes of time, we are going to move on. So I'd like to start by highlighting some of the many health benefits of resistance training in women. So resistance training in women has beneficial effects on cardiovascular disease risk factors, including blood pressure, glycemia and insulin resistance, lipids, body composition, sleep, depression, anxiety, and chronic inflammation. Resistance training is associated with reduced risk of all-cause cardiovascular and cancer-specific mortality, and there is an additive effect of muscle strengthening exercise to aerobic activity on mortality risk reduction, with a minimum effective dose of 1 to 2 times per week. During the menopause transition, resistance training of moderate to high intensity has been shown to lead to improvements in lean mass, muscle strength, and bone mineral density during early postmenopause. And resistance training has been shown to be more effective than other forms of training like walking, Tai Chi, and endurance training. Among postmenopausal women, resistance training across all intensity categories, so low, moderate, and high intensity, has been shown to improve bone mineral density in postmenopausal women. Higher intensity resistance training does appear to correlate to greater improvements in bone mineral density. And the combination of resistance training with other weight-bearing, high-impact aerobic activities, such as jump rope, running, tennis, those types of activities, appears to be most beneficial for bone health in women. Research suggests that impact-only training, so women who are only running, only playing tennis or pickleball, that's largely ineffective. So really that combination is going to be most effective for them. So exercise is recommended for postmenopausal women who have a diagnosis of osteoporosis. There's good quality research suggesting that exercise interventions can reduce falls and prevent fractures among postmenopausal women with osteoporosis. And exercise has been shown to increase bone mineral density, although the benefits are generally small, still on the order of 2 to 3% increase in bone mineral density with exercise, including resistance training, impact activities, and walking. There are some contraindications to resistance training, so these are important to review when counseling your patients and developing an exercise prescription, so these are listed here. Before we design an exercise program, it's important to try to understand the different components of resistance training. So the 3 measures of skeletal muscle fitness are strength, endurance, and power, and each of these can be improved with a resistance training program. Strength is the greatest force that a muscle can exert in one effort. So how much can you bench press once, for example? You can optimize this by lifting heavier weight with a lower number of repetitions. Endurance is the muscle's ability to make repeated efforts. For example, how many push-ups can you do in a row? You can optimize this by lifting lower weight but a higher number of repetitions. And power is a measure of how quickly muscular strength can be applied, and this can lead to improved speed and agility in sports. So this is an example of how you can design a resistance training prescription. For most of the general population, you'll be starting at a moderate intensity program. So this is about 40 to 60% of 1 repetition maximum. So the 1 repetition maximum is how much can you lift, the most weight that you can lift for 1 rep. Your sets will be composed of 8 to 12 reps. It's recommended to do this at least 2 days a week, and this is going to help promote both strength and endurance when thinking about those different measures of skeletal muscle fitness. Now, if you have higher risk patients, you may start them at a lower intensity program, less than 40% of a 1 rep max, or for healthy adults that are really trying to optimize their strength, you might consider a program starting at a higher intensity, which would be more than 80% of a 1 rep max. So for most healthy adult women, to design a resistance training prescription, the goal will be to include at least 8 to 10 different exercising involving the different major muscle groups. So this is just one example of an exercise program, and you can see, I apologize, it is a little small, but these different exercises are really targeting all the major muscle groups in the upper body, the lower body, the core, the spine. The idea is to design a program with 1 to 3 sets of a moderate intensity load that allows you to complete 8 to 12 repetitions per set. So if the load is too high and they can only do 4 or 5 reps, then they need to start at a slightly lower weight. Or if the weight is so low they're easily performing 15 to 20 reps, that weight does need to be increased a little bit. So the idea is to be at a 40 to 60% moderate intensity load that you can sustain for 8 to 12 repetitions. The recommendation is to do this at least 2 times per week, and rest days between sessions are optimal for neuromuscular adaptations. And these exercises can be completed using machines, free weights, elastic bands, or body weight, depending on the patient's previous level of activity and their comfort level with these different exercises. In terms of progressing the weight, as we mentioned before, the initial intensity should be about 40 to 60% of a 1 repetition maximum. However, it is very important to gradually increase the resistance, the number of sets, or the frequency of training over time. This is a concept we refer to as progressive overload, and progressive overload is required to see those many benefits of resistance training that we described earlier. To help patients guide them on how to increase the weight and the load, you can use the 2 for 2 rule. So when an individual can achieve 2 or more repetitions of a given exercise on 2 consecutive sessions, they can increase the weight of the exercise by 2 to 10%. So this is an easy rule of thumb that you can share with your patients to help guide them on when it is appropriate to increase that weight, because again, that progressive overload is essential to see the benefits of resistance training. And finally, I'd like to take a minute to review the benefits of resistance training in adolescent females. So there are many benefits, including musculostrength, endurance, power, injury prevention, cardiovascular fitness, body composition, bone mineral density, blood lipid profiles, insulin sensitivity in overweight youth, and mental health. And although the many controversies on this topic and many parental concerns that I get in clinic all the time, there are no apparent negative effects of resistance training on linear growth or physeal health in appropriately designed programs, and this is really key. So the emphasis should be on properly designed, technique-driven programs that follow a developmentally appropriate progression and are supervised by qualified professionals. So this might be a strength and conditioning coach, a physical therapist, another type of coach, and often in younger patients, this really just starts with body weight exercises, including some of the ones, for example, in the FIFA 11 program that we saw with Dr. Wong earlier. And among adolescents, bone and muscle strengthening exercises and activity should be performed at least 3 times a week. All right. I think for the purposes of time, we are going to skip ahead to the last case, but these slides are available in the syllabus. All right, so our last case for today, so we can leave some time for questions at the end. So a 16-year-old female cross-country runner presents to clinic complaining of fatigue and low energy. She states she often misses training due to frequent illness and recurrent injury, which affects her mood. She reports a healthy vegetarian diet. On a review of systems, she also complains of cold intolerance and irregular periods for the past year. Which of the following would you do next? And this is actually a select all that apply, so I'm not sure that the polling will work here, but you can, yes. Oral contraceptive pill. Thanks. So go ahead and chat with your neighbor. Think about this one for a second. Oh, I don't know if I can go back. Oh, wrong one. Next polling question. Okay, great. I love this. Okay, so the two most popular answers were the two correct. So these are actually both correct, and we'll learn about why in the rest of the slides. All right, so this patient's presentation is concerning for relative energy deficiency in sports, also referred to as REDS. So REDS is a clinically diagnosed syndrome of impaired physiological and or psychological functioning that can be experienced by both female and male athletes. That's caused by problematic, which is either prolonged or severe exposure to low energy availability. And low energy availability is defined as any mismatch between dietary energy intake and energy expenditure through exercise that leaves the body's total energy needs unmet. So this can lead to the body's inability to have enough energy to sustain normal physiologic function and overall health. Now, the most well-documented detrimental effects of low energy availability are on bone health and reproductive function in females, and this is often described in the female athlete triad syndrome. But REDS is really an expanded concept beyond the female athlete triad syndrome that includes detrimental effects on a number of other health systems in the body, including but not limited to impaired metabolism, hematologic function, immunity, cardiovascular function, reproductive function, GI function, bone health, mental health, neurocognitive function, sleep, and musculoskeletal health. And this can lead to impaired well-being, increased injury risk, and decreased sports performance. REDS is higher risk in female athletes that participate in aesthetic sports such as figure skating or dancing, endurance sports such as cross-country running, or weight class sports such as wrestling or rowing, and really any sport that's going to associate lean or thin body with athletic success. It's very important to screen for REDS. If there's any patient that you have with any of these features that we described, or if you have any concern as a provider for relative energy deficiency. The Female Athlete Triad Consensus developed a list of screening questions listed here, and many of these are incorporated into the PPE if you're doing a pre-participation physical exam for high school or collegiate athletes. But even outside of this setting, it's very important to ask these questions, or at least some of them, if you have any clinical suspicion for this. I'd like to start by highlighting some of the more well-documented adverse effects of low energy availability. So first, impaired reproductive function. Some of the manifestations are going to be primary amenorrhea or secondary amenorrhea, which is often referred to as functional hypothalamic amenorrhea, or really any other menstrual irregularities that don't meet that criteria of oligomenorrhea. In terms of management, I recommend checking an estradiol level if the patient is not on a contraceptive, otherwise it will not be helpful. Workup to exclude other causes of secondary amenorrhea, or a referral to endocrinology if indicated, and a referral to a sports medicine specialist for a REDS evaluation after excluding other causes. We're also happy to complete this workup if it's something that you're more comfortable with us doing in primary care sports medicine clinic. In terms of impaired bone health, some of the manifestations are low bone mineral density or a lack of the expected bone mass accrual in adolescence. And this is really important because adolescence is the time of peak bone mass accrual. And so these deficits can be really impact overall bone health for the patient's lifetime, including their long-term risk of osteopenia. Bone stress injuries ranging from stress reactions to fractures as well. In terms of management, I recommend checking a vitamin D level, vitamin D and calcium supplementation, and then referral to primary care sports medicine for bone health optimization, which may include getting a DEXA if indicated, other labs, talking about medications if indicated, or if there's any concern for a bone stress injury. There are also adverse effects on other health systems like we've seen. So there can be impaired energy metabolism and regulation, and some of the manifestations of that include subclinically or clinically low T3. And total T3 can be a really helpful biomarker of metabolic suppression. So I really rely on this a lot, especially in patients who are on OCPs and we don't have the presence or absence of periods to help us get a sense of what their overall energy availability is. You can see a low resting metabolic rate and increased cortisol as well. So in terms of management, I recommend checking a TSH with a reflex T4 to exclude hypothyroidism, as well as a total T3. You can consider referral to endocrinology if there is evidence of hypothyroidism, as well as referral to primary care sports medicine for a REDS evaluation after excluding other causes. In terms of impaired hematologic function, you can also see low iron and ferritin and reduced iron absorption. Many patients can have low ferritin and low iron stores even in the absence of anemia, although some patients will also have anemia with a low hemoglobin. I recommend checking a CBC, iron studies, and a ferritin. You can consider additional labs to exclude other causes of anemia if present, and a referral to hematology if indicated. Iron supplementation, and again, referral to primary care sports medicine for a full REDS evaluation. So many patients with REDS exhibit disordered eating behaviors. And disordered eating behaviors exist on a continuum between optimized nutrition and a clinical eating disorder. And many patients can have unhealthy, abnormal, disordered eating behaviors, but not quite meet criteria for a clinical eating disorder. And it's really important to try to identify any red flags for disordered eating by taking a very thorough dietary history. So any history of special diets or avoidance of food groups, for example, if the patient states that they're gluten-free but don't necessarily have a history of celiacs or just have a gluten sensitivity, a low-carb diet, if they are low dairy, say that they're lactose intolerant, vegetarian, or vegan, and you kind of push them and try to understand their reasons for that. And certainly some patients have these dietary habits for personal, religious, cultural beliefs, but this can certainly be a red flag, and research suggests that these special diets are predictive of patients with disordered eating. You want to ask about number of meals per day. Are they eating 3 meals a day plus snacks? Are they fueling before and after their training sessions if they're higher level athletes? What's the composition of their meals? Is it a plate full of carrots and lettuce? Is it well balanced? These are really important questions to dive into. Are there any weight concerns, either their own weight concerns or from external pressures, coaches, parents? Do they worry about their weight? Is there a history of any calorie counting or intentional restriction of intake, or a history of an eating disorder? And often you can have low energy availability even in the absence of restrictive eating. This can often be unintentional, and I think that's a really important consideration when working with athletes. You can have an unintentional low energy availability if you're just training more than you're consuming. So if that mismatch between energy in and energy out can be unintentional if there is just too much energy expenditure and not enough fueling to balance that out. In terms of management, I recommend checking a CMP, lipids, referral to a dietitian, referral to primary care sports medicine for a REDS evaluation. And if you are concerned about an eating disorder, these patients do need to be referred to an eating disorder specialist and mental health services. All right, so thanks for your attention, and I think we have a few minutes for questions.
All right, we'll start with one on the app. So regarding the 12-week postnatal exercise progression, what restrictions are there for upper extremity, seated or standing exercises? When can they implement upper extremity exercises versus lower extremity?
Can you hear me okay with this? Okay, great. That's a good question. So this is really going to be individualized and symptom-based. So patients may be able to resume upper body seated exercises sooner than higher impact. So, as long as they don't have any of those contraindications listed on that list or the Get Active questionnaire, and symptomatically they're able to complete those exercises without worsening of any symptoms, as we've discussed. And, again, assuming that perineal tears or surgical incisions are well healed, they're not having any increase in pelvic floor symptoms or bleeding, they could certainly resume those exercises sooner than higher impact. There's not a specific time that they need to wait. It's really going to be individualized and symptom dependent. So it could be much earlier, 2 weeks, 3 weeks, 4 weeks. A lot of this will depend on how they're feeling, and as long as they don't have any of those red flags that we discussed.
Then another question for postpartum status post uncomplicated vaginal delivery. I have only been taught and advised my patients for pelvic rest, not pelvic inactivity. And for C-section, the same restriction as any open abdominal surgery. 12 weeks seems incredibly long with the numerous benefits and promotion of healing it facilitates. Can you comment on this?
Yeah, I agree. The research does suggest early initiation of pelvic floor rehabilitation and the many benefits that come from that for prevention of things like urinary incontinence and prolapse. This would need to be a discussion to be had with the OBs, as these are post-surgical patients. But again, it will depend on the presence of any surgical complications, C-section, incision healing, presence of any symptoms or bleeding. But the research really does suggest early initiation in the initial postpartum period for pelvic floor rehabilitation. So that should be a discussion that can be had with the OB regarding the safety of resuming that sooner. But I agree that more recent data supports earlier initiation sooner than 12 weeks.
And then I would say too, for those who aren't as familiar with pelvic floor physical therapy, a lot of the exercises are centered around how to breathe, how to engage core and abdominal muscles, your diaphragm, and how that interacts with your pelvic floor. So it's not like we're telling people go to the gym and lift really heavy weights or squat or do all these crazy things. A lot of the exercises are simply breathing and learning how to engage your pelvic floor while you do that. So if you keep that in mind when we say start pelvic floor physical therapy right away, I mean, it could simply be as simple as that, not necessarily doing any significant resistance training, but just trying to re-educate and then re-engage those muscles. And see your local pelvic floor PT for help. We also have a lot of great community partners as well as pelvic floor PTs at UCSF. So if you need any connections or don't know who to refer, how to get your patients to pelvic floor PT, please let us know. We also have great pelvic floor PTs at UCSF if you're local.
Thanks for the great talk. Opposite spectrum of that, do you have any specialists in the Women's Center for aging athletes, a particular specialist who can work with women who still want to be maybe not competitive on a national or state level, but competitive in their own lives? And or as a group, I'm sure you see them, but do you have one or two specialists in this age group?
Yeah, I think any of us would be comfortable and happy to see these patients. I think we really specialize in caring for female athletes across the spectrum, ranging from young children and adolescents all the way to aging adults. So I think any of us would be happy to see those patients and be able to guide them.
Thank you for the talk. So I'm Korean, and my family gave me a lot of postpartum advice, specifically my mother. She was horrified by a lot of things that I did after I delivered my kids, and which is very in contrast to a lot of the evidence that you presented in terms of resuming activity and even some of the exercise and strength training. So curious if there's studies or in the literature looking at cultural norms and sort of how that affects recovery, and if people have actually looked and seen any of this in any kind of evidence-based fashion.
Those are really good questions. So, there are variations among global guidelines, and, the ones that I presented were primarily American and Canadian. So thank you for that comment. The research in this area is certainly limited. It's increasing over the past 5-6 years. Maybe over the past decade, but it's still a budding area of research. So I'm not specifically familiar with any research on this. There may be some people in the back, Dr. Chang, who have some comments on this, but I think it's a really important question.
Yeah, I think so. Sports Medicine Societies International, like Japan, has a wonderful postpartum after I had my baby, my mom said you can't go up and down the stairs for 6 weeks. So have your husband do the laundry. So, but I will say that it really depends, right? And this is generationally, what's happening is more and more women, young girls are exercising, transitioning into adulthood, continue to exercise. That's what we have to promote. And that will change the cultural norms because of essentially what's happening. But great comment, absolutely great comment. I haven't seen any studies actually looking at that, but what a great study.
Yeah, and I do think it's not all or none, right? Like I think there are some features of especially like Eastern postpartum care, which, yeah, maybe other people can do the laundry, right, Cindy? Or maybe, so I think, I think we can do both, right? We can kind of bring in exercise rehabilitation. It doesn't need to be like pure bed rest. Like in Chinese culture, it's like stay in your bed for 40 days. It can be a little bit more nuanced than that. But a lot of, I think the other things are support, the person who delivered, eat healthy meals, et cetera. So I think it can be incorporated, but yeah.
What I would add is among all of these guidelines and recommendations, every little bit counts. So it doesn't need to be going out for a 20-minute stroller walk up the hill. It can just be going for a 5-minute walk. It can be going outside for a few minutes when you haven't seen the daylight in 2 weeks, right? I remember those days. So I think every little bit counts, and all of these guidelines promote having that wraparound support from family, from friends, but from society, right? And this is growing and this is developing, but this is still really a big societal shift that needs to happen, and every single one of you can play a role in that.
Thank you for your talk. So I am training high school girls, doing strength and conditioning, and I find the really hypomobile girls very challenging because when we try to do just body resistant exercises, their knees are this way and their body's that way. So is there certain muscle groups that you have to focus on first before you start employing further strengthening training for them?
Yeah, and if you're a PT in the room and want to weigh in, please feel free. I always just say, if you attended my hip talk, I just preach core and glutes. It all starts from there. That's essentially the long and short of it. But I think, it's interesting time, I think, in adolescence. Your body's changing a lot. You're also demanding a lot of your body as well. And so as young athletes kind of grow into their bodies, like things will change. But I think just teaching them how to engage their core, like where their core is. I always say we all have those muscles, just some of us use them more than others. And then engaging glutes and understanding how those work as well is super, super important. So clamshells are your friend, right, Danny?
Clamshells are not my friend. No. It's always the glutes, always. Awesome. Well, we are out of time, unfortunately, but thank you guys so much for a great talk. I don't know if this works. Be sure to. None of these work. I'm gonna have to talk louder. Be sure to check out our Women's Sports Medicine Center, guys. It's a really good resource, and if you have any patients that need additional resources or information, it's an incredible group of clinicians and physical therapists. So please, 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 please send people that direction. We're gonna take a little bit of a break, and then we've got a great talk on nutrition, which is a great segue. So thank you guys, and have a nice break.